Dr. Will Aldridge is an investigator with the Frank Porter Graham Child Development Institute at the University of North Carolina at Chapel Hill, and an implementation specialist with the National Implementation Research Network at UNC. His work includes intensive technical assistance and applied research on active implementation of evidence-based practices across human services and community settings, particularly in relation to mental, emotional, and behavioral health and public health approaches to prevention. Prior to his work at NIRN, Dr. Aldridge was an early career scientist and member of the steering committee of the Promise Neighborhoods Research Consortium, a national group of prevention scientists and community members funded by the National Institute on Drug Abuse to assist high-poverty neighborhoods translate existing knowledge into improvements in community well-being.
First of all, just thank you very much to Congressman Cardenas and Scott and Finninger for having us here. What I'm going to share is just 4 basic points. This is what I was asked to speak about. What are 4 take-home points for policymaking? Related to the implementation of evidence-based prevention programs. Also want to acknowledge that this work really came out of our full group, so I want to thank them for their contributions, and this is a collaborative project here. First off, now it's time for our interactive portion of the panel. A couple of program choices here, and I want you to tell me, for your family, which program would you like? Here we have a school behavioral health program that's designed to reduce aggression in school settings. What do you think? Program A, which has very modest outcomes, or Program B, which has pretty significant outcomes? B. All right, good choice. How about this one? This is an employment program in adult mental health. We're looking at the percent employed. Program A has okay outcomes, and B has significant outcomes. B. All right, you're going true to form. Adult substance abuse treatment. Now we're looking at percent of clean urine screening. So modest outcomes with Program A or significant with Program B. Well, here's the kicker. In each chart, A and B were actually the same program. Well, how does that make sense? Program A was a low-fidelity implementation of an evidence-based program. Program high fidelity. And what I mean by fidelity is that these programs were being delivered as they were designed, as they were intended to be delivered. So number one, first thing you need to know is that fidelity predicts outcomes. Before any changes are made or adaptations are made to an evidence-based program, they need to be done as intended so we can have confidence in the expected results we're going to get. What does this look like in policy? As federal funders, you need to make sure that you're getting the prevention programs you're paying for. And one way to do that is to start requiring fidelity data in your grants and in your contracts so that there is evidence that if it's a particular program, that program is actually there and being done as intended. Well, that's nice. Fidelity predicts outcomes. Well, but what about doing this at scale? Has this been done at scale with fidelity and impact? This is some data from Colorado and trauma-focused cognitive behavior therapy. This is a program for kids who have experienced trauma in their life. And this looks good because this is a density map. They've got 439 clinicians trained across Colorado. That's wonderful. Similarly, Triple P in North Carolina, they're in 33 counties now, and what I'd like to highlight about this one is the blend of funding. So the green counties you see here are public health money. There's also federal money through SAMHSA and CDC, as well as a private foundation that steps to the table. So we have evidence of going to scale and blended funding. This is long-term system-wide wraparound services, which are for the most difficult children across all settings. This was done in Kansas. On the left here, what we have, you see going up, is the number of children that are actually being served. From 98 to 2004, you have a dramatic increase in the amount of kids being served. And hey, we have impact, right? So if we look at the same years, this is institutionalization data, the number of days that are spent for these children to be institutionalized, and a dramatic decrease in institutionalization. Last one on this is, here's functional family therapy in Washington State. What you're looking at in these bars are actually 25 different therapists and their caseloads. The prevention here is to prevent juvenile offenders from coming back into the system. So we're looking at recidivism. Well, down at the bottom is the control group. If you look at that control group, 22% recidivism. Well, look at the distribution here. This is an evidence-based program. The distribution is not too far away from the mean. Well, how do we make sense of this? Our top 12 therapists, these are therapists that are actually meeting fidelity criteria. Their recidivism rate for their caseloads was 13%, a vast improvement. The bottom is below fidelity criteria, and their recidivism rate is 28%. It's actually worse than the control group, and this is what an evidence-based program. And this is what we typically see in service settings when evidence-based programs are being rolled out at scale. Here's another picture of this. This is comprehensive school reforms. The idea here is to take these research-based interventions and get them into school settings. Well, when these were developed, and this is the key, every teacher was trained in the research trials and then supported over the long term. But this is a couple of longitudinal studies looking at comprehensive school reform, and it found that fewer than 50% of the teachers in these 8,000 schools that stepped forward and said they'd do this, fewer than 50% of the teachers actually received some training. Less than 25% were actually given support after their training. And then in the years 4 and 5, fewer than 10% were actually using the comprehensive school reform as intended. And the result of this is the benefit. Again, this is in 8,000 schools. Our federal government has spent $2 billion on this. And this is a picture of Virga. I don't know if anybody's familiar with this. The idea here is that rain is falling, but it's not reaching the earth. And it very much feels like this when we're doing implementation work, because we have this great science, and it's not making it to the ground in our communities and in our schools where it can have the impact. Why is this? Well, methods of doing dissemination are not working. Whether it's passing out information, simply offering training, actually passing laws and mandates is in this group as well. All of these are necessary, but when done alone, they only get about 5 to 15% of intended outcomes, that the programs are actually being used as intended. It's almost like we're expecting a miracle to occur, that we're putting these programs in these systems, and then somehow, some way, if we just tell them they have to do it, if we just give them training, they're going to make it happen. And it's not working. So here's the second thing you need to know, and it's our formula for success, which basically says we need effective interventions, but we also need effective implementation methods and enabling context. We need host systems to make these programs go. This is a multiplication problem. Anything times 0 is? 0. So you can have an effective program in the world, and if it's poorly implemented, you're not going to get the outcomes that you're expecting. My colleagues at the National Implementation Research Network over the past 10 years have been synthesizing the implementation research to help go from making lists of different strategies to making sense of how do we do this active implementation work. We've organized these in 5 different, what we call networks, to help guide systems and agencies through the implementation process. And we do a lot of training and technical assistance as well with these agencies to help put these strategies in place. So what does this mean for policy? Well, any policy that uses evidence-based prevention programs needs to include effective implementation methods, these active strategies coming out of applied implementation science, which is so, and again, we're like dropping these programs in there, and we're expecting these systems that have operated for so long in a certain way to all of a sudden start behaving differently. And that doesn't work. My favorite quote is the one at the top, that all organizations and systems are designed intentionally or unwittingly to get exactly the results they're getting. So if we want different results, we have to help transform the system. This is our third point, the third thing you need to know, that full and effective use of these strategies requires an active, supportive, and often transformed organizational or systems environment. Well, what are some strategies for achieving that? I'm going to touch on a few of our frameworks here. This first one is what we call implementation drivers. It says that if we know we want socially significant outcomes, and we know what predicts that is using the programs as intended, how do we build infrastructure and best practices to support that? We need certain things around building staff competency and confidence to deliver these programs as intended. That's where we get into selection, training, and coaching programs, putting in place fidelity measures. We also need to build institutional capacity. That's where we get into these things around data support, decision support data systems, and leadership to provide direction and change and manage it along the way. And we have some examples. This is actually from Allison Metz, who's here in the audience in the white coat. I'll see with her out. This was done in North Carolina, and we tracked these implementation drivers over time. We have those on the left, and these are on a scale from 0 to 2, which 0 means that that driver is not in place. 2 means it's fully in place. So if we look at time 1, we're worried about a composite score. So all these drivers are partially in place. And look at our fidelity percentage, 18% fidelity. But then we were made intentional, purposeful efforts with the local community to improve these drivers and look at the fidelity scores over time. If we increase this infrastructure and we have ways to measure this, we're getting a significant bump in fidelity, which makes it outcomes. Another thing we like to put in place are some continuous improvement methods. Things like usability testing, which businesses do all the time, to put a strategy in place, make it usable, and before scaling it up. Also, practice the policy communication cycles. We're really good at this first loop of planning and then doing things. We need to build in feedback systems so we can get information from the ground level, the practice level, to feed back up to policymakers so that they can then review what's going on, reiterate the policy to improve it over time, and by doing that policy starts to enable practice. And lastly, a structure that we like to put in place is what we call implementation. There's a train of thought that says, well, we just need a champion, we need a hero, we need a transformative leader. But the question is, what happens when that leader goes away? The whole thing tends to fall apart. So what we do is, instead of talking about just champions or one person, we put in place implementation teams. These are a group of about 3 to 5 people in the organization that have the responsibility for ensuring the implementation happens, installing those drivers and the continuous improvement methods, engaging the community, creating a hospitable systems environment, and using data for decision making. And we have evidence that these implementation teams are important. The traditional way of looking at this was a couple of studies, a study done by Ballas and Warren, it's been widely publicized, says that it takes about 17 years for 14% of science to actually get implemented. Okay, 17 years for 14%. We have some initial evidence that when we put in place these implementation teams, we may be able to decrease that to as little as 3 years and get 80% of the science in place. So they tend to be particularly important. What does this look like for policy? All right, so this is number 3 to 4, so almost there, is that we need to set aside funding so that systems and organizations can commit to building this new infrastructure or repurposing their existing infrastructure. So having some funding, some allocations for that so they can do that and embed these practices. Last thing, 4th thing you need to know is that this takes time. This is not a popular thing for legislators and politicians that work on 2 to 6 year cycles. But to take a single usable intervention and fully scale it, where we would expect to see the outcomes, takes 2 to 4 years. And that's one program. If you actually then go and scale that program, it takes additional time beyond that. And so not only does it take the time, but there's a series of progression of stages that these organizations and systems go through. And we need to protect the activities that are important at each stage of the implementation process. So last slide, here's policy recommendation 4. Initiatives need to allow for stage-based activities. Having a planning year to do that exploration work can be particularly helpful. A lot of times they jump straight into implementing and they realize that the foundation is not there to do the program that they're doing. And building a realistic time frame so that we can be confident we're going to have enough time to get the expected outcomes. Feel free to ask for more information. Again, my colleague Allison Metz is here. We have some handouts over here. I see they've been beaten up, which is great. And we also have an e-learning hub now as well online to learn more about the active implementation frameworks and strategies in them. So thank you very much for your time.